Okay, and we are live streaming now. Hi everyone, welcome to the Media and Health Symposium here at Virginia Commonwealth University. We'll get started in just a second. We'll give everybody a chance to join us and to view our live stream, so it'll be about a minute until we get started. Okay, hi everyone, and welcome to the Media and Health Symposium here at Virginia Commonwealth University. We're very excited that you're joining us, whether you're sitting in our audience room here at the VCU or you're joining us via Google Hangout virtually. We hope you enjoyed the keynote speech by our speaker Brian Ellis of Padilla CRT. We're now turning to our first research panel. We ran a peer-reviewed paper competition late last year, and so you will now in this first research session see three research presentations on the uses and effects of mobile and social media in health communication. And our researchers for these three presentations are Yanni Li and Yan Jin at the University of Georgia, and they're both joining us in this Google Hangout. We also have Nicola Kroemer, Constanze Rossmann, and Peter Schulz. Nicola and Constanze Rossmann are of the University of Erfurt in my home country of Deutschland, Germany. So a great welcome. And Peter Schulz is of the Università della Svizzera, Italiana. I hope I said that correctly, and that's located in Switzerland. And Nicola is joining us for the presentation. We also have Weirui, Wang, and Julie Yu of Florida International University joining us. Actually, Weirui Wang is a presenter. So welcome everybody. We're very happy that you're joining us in this hangout. I'm also very happy to welcome our discussant, Robert Logan from the National Institutes of Health, who is actually a great supporter of our center and our symposium. He's a member of the advisory board of our center. So welcome, Rob. We're very happy to have you with us as well. Each of our speakers will present for about 10 minutes, and then our discussant, Rob, will provide them some feedback, and will also give our audience a chance to join the discussion, to ask questions. And you can do that either in our audience room here at VCU. You can ask your questions live in the Google Hangout, or you can just post your questions on Twitter. If you do that, please use the hashtag VCU Global Health. You can already see that there's a lot of conversation going on in the background of our symposium. Also follow our center's Twitter account at VCU CMH, as some of my colleagues are tweeting as well. So let's get started with our first presentation. And we are all, or most of us, are using Google Hangout actually for the first time in a live setting. So give our presenters just a second to pull up their presentations. We want to make sure that they're displaying right, and then we get started. And so our first presenters are Yanni Li and Yan Jin from the University of Georgia, and their study is Media Platforms, Health Interest, and Individual Factors in Predicting Health's Mobile App Use, the Conceptual Framework. Yanni and Yan, please pull up your presentation, and you're all ready to go. and you have to unmute your mic.
Okay. So can I hear us? Can you hear us, Marcus?
I can hear you fine. We cannot see your presentation yet.
Okay. So it's coming. Okay. Okay. Is it okay now?
Looks great.
Okay. Wonderful. Well, first of all, I'd like to say good to see you, all of you guys here, and also to my VCU friends and former colleagues. It's always good to be virtually back to VCU, to Richmond. And also our University of Georgia, our Center for Health and Risk Communication, would like to send our regards to our colleagues at VCU Center for Health and for Media and Health. Okay, so before we get started, a little bit kind of connection to the wonderful keynote speech we just all listened to earlier. As Brian mentioned earlier, that the mobile is where it is going, and also from a crisis communication perspective, just like organization needs to manage crisis and issues, as individual in our daily life, we are constantly facing the challenge to anticipate and also manage health issues. Okay, so as scholars, how do we anticipate, how do we identify and hopefully predict the trends in health communication? That's in that spirit that Yan Li, our doctor student at University of Georgia, and I started to think about a conceptual framework integrating existing theories and concepts, and also reflecting conversations and questions and insights from health communication practitioners. So we're going to present you a framework we are developing right now, mainly to identify what kind of external and internal factors that will motivate individuals to utilize health mobile applications, and also what kind of factors might actually serve as something that preventing them from more effective engagement using those apps. So now I'm going to turn to Yan Yi for her to lead the discussion and also share with you what we have so far.
Hi, everyone. Okay, so thank you for coming, for joining this panel. So now from this slide, actually, we can, from these numbers, and then we can see actually a smartphone and then a health mobile app use has been increased. So actually this kind of gives us an idea. It's a very important tool for people to access information and also manage the health information. And also from this information, we can see like the mobile apps have been connected with like a health-related issue. For example, healthcare, or between the doctor and patient communication, or like the health information management. And then so now from this slide, we also can see many mobile app study, actually they more from the marketing or computer science and medical fields, and also they more focus on the practical function effects. So this is give us some idea to think about what kind of a theory. It seems still limited theory to use for this mobile health app study, and then also we still some limited study. They look at this issue from the user's perspective, such as what kind of internal or external factor can influence they want to use this new technology. So this is why we start have this framework come out. So before we go through more some concept framework, from these slides you can see some definitions about the mobile apps, and then the definition for the health mobile apps. So based on this definition,
Jenny, can I interrupt for a second? We don't see your slides move forward. Maybe you need to pick one of the other slide sharing modes on the left-hand side. So we're only seeing your title slide right now.
Okay. Okay. Is it working, Marcus?
You should on your computer, you should put your presentation into full presentation mode.
Yes.
And then you click Alt and Tab, and you go to the Google Hangout, and you click on Screen Share.
Okay.
So for now, if you can end the screen share that you have right now, so just end it so that we can see you on camera.
Okay.
Okay, and then if you can go into the PowerPoint and make it display.
Yes.
As the full screen display.
Yes.
You run the PowerPoint, and then you click Alt and Tab on your keyboard.
Okay.
And you move the tab forward to the green speak bubble that you see. You see that Google Hangout bubble?
Yes.
And you go there, and then you share the full displaying PowerPoint. Then you're back in Google Hangout, and you click on the share, and you click on that slide that shows the full display of your cover slide. Do you see that?
Okay, got it.
Okay.
Okay. Okay.
And then I'm going to mute my mic, and you'll be able to, with just the tabs on your keyboard, to move forward and back.
Okay. Is it working now, Marcus?
Yep, working great.
Okay, perfect. Thank you. Okay, let's continue.
Okay. So now let's continue to just have some brief idea of what is the definition for the mobile apps and the health mobile apps. So based on this definition, actually we know two really important things for the mobile apps is user need to run software on their cell phone. And also the second is a dual process of interactivity. So based on this some definition, actually kind of guide us the direction to operate the concept of the health mobile apps used by asking participants like having health mobile app on their cell phone, and how many numbers do they have and how frequently they use it, and then what type of mobile health app they use, and then why they want to use them, to give us maybe more clear definition in this field study. So now let's go to the first conceptual framework is the multimedia platform. So because the new technology development, and then now many people they use different multimedia channel to access the information. So what is the multi-platform? It means a consumer can consume the different platform at different time and the different content in different platforms. So for example, I can consume the health content or information from the TV or from my mobile phone and the social media. So this is the multimedia platform idea. And then so this idea can provide us maybe a direction to know users' media use behavior or their pattern and also their preference. So this is can let us know maybe what kind of the pattern for the user to use this smartphone and then mobile apps you use. And also within the health topic is important factor to increase people awareness, and also maybe can motivate them want to use technology to manage their health information and health condition. So based on this idea, we have the first proposition would like to discuss is this multimedia platform and health topic interested jointly predict the mobile health app use. The second concept is interactivity. This is more go back to look at this the technology feature, because from some study we know interactivity is very important for the new technology use. So for example, whether this technology easy of use or is make user feel like a coolness, or they can control to access or the seeking for information. So this is why we also would like to test this the concept to see how this interactivity concept can influence their health mobile app use behavior. So this is why we have our second proposition we'd like to discuss is a certain interactive feature of the mobile apps. For example, ease of use, control, or coolness are associated with health mobile app use, especially for the younger generation. So the next is concept is self-efficacy. So according to the Pandora definition for the self-efficacy, is related to individual confidence in the ability to perform various level of action and then produce a specific outcome. So based on the past studies, we know like demographic factors or that help-seeking intention, or even though this can related to the self-efficacy on health behavior and choice. And also since the technology came out, and then there are more scholars to use this self-efficacy to kind of extend new area with a new area. So for example, have the computer self-efficacy, or even though they use a self-efficacy into the health area, they will have a different term. It's called a health efficacy. But based on the original idea, they are looking for how people feel confidence to manage their health outcome by using the technology. So this is a kind of the self-efficacy idea. So based on this idea, we have the third proposition to want to examine or discuss about people with a high self-efficacy tend to be more willing to use health mobile app than people with a low self-efficacy, because they have more confidence to think they can use this technology to control and manage their health situation. And then the next concept is anxiety. So we before the interactivity or like this health app definition, it's more like the goal toward external factor, and then the self-efficacy and then the anxiety, we switch our angle to look at more like internal factor for user to use this mobile health mobile use. So anxiety, which means emotional fear and then apprehension by individual toward interaction with subjects or toward those of a behavior. So anxiety is it can influence people's decision making or the information seeking, even though their health risk perception in different levels. So but when we look at anxiety study, we found most of the study they focus on either how new technology use. Like how scared, how fear they use new technology, or they consider anxiety as a symptom. So for example, they will look at the effects of new technology use on treatment of the anxiety. However, we think it would be better to extend this idea and then to go back more like the user perspective, and then to see how this psychological factor influence their maybe motivates to use a mobile health mobile app use. And also it also can help us to look at either like the anxiety with the technology and anxiety for the health. These two factors is kind of separately influence individual, or actually mutual influence each other. So based on this idea, we have the first proposition want to discuss is about individual self-report anxiety about their health and the technology as is associated with a health mobile app use. And then another concept is more like a theoretical framing. Is called the uses and the gratification theory. So this theory is deal with how individuals actively manage their choice of the media use in satisfying their social and psychological needs. So based on this definition, need and motivation are very important factor for people behavior of using technology. So because need and motivation are important, so there are many scholars, they provide different need and motivation categories to examine some related health issue. However, based on our previous concepts like interactivity, health, topic interest, and self-efficacy, and then we will come more specify three motivation category to examine how people feel satisfied to use a new technology, especially health mobile app use. And these three motivation categories are entertainment, socialization, and information seeking. So based on this idea, we have our fifth proposition we would like to discuss is health anxiety, technology anxiety, self-efficacy, app, interactivity, and motivation jointly predicts health mobile app use.
Mm-hmm. Okay, yeah, so to summarize, so in this process of reviewing literature and conceptualizing, what are the key factors that might be potentially contributing in the variance in people's different level of using or using and engaging in health mobile apps? So there are like three major categories. We have media platforms, we have different health interests, and also individual factors in terms of the motivation, in terms of their emotional status, for example, like anxiety level for health condition, and also for using technology in general. So we're hoping that the next step, we're going to start to collect empirical data to actually testing the different linkages in this network of factors, and then to see how these factors associate with each other, which factor will be mediator, which factor will be like most influential contributor in predicting different types of health mobile app use. So thank you for coming to our presentation. So we're looking forward to any suggestions or questions or any thoughts from our audience that will really helping us improve this conceptual framework. And so we'll be even more ready when it comes to testing the different propositions. Thank you, guys.
Okay, thank you very much, Yang and Yen. For our audience, if you have any questions for our speakers, please start posting them on Twitter using the hashtag VCU Global Health. So thank you very much for that presentation. Our next presenter is Nicola Kroemer of the University of Erfurt, which is in Germany. And she's presenting a study, the effectiveness of mHealth interventions for diabetes self-management, a systematic literature review of mHealth's effects in relation to intervention time frames. So, Nicola, you have to unmute your mic, and maybe we can test right quick if your presentation displays right before we get fully started.
All right. Can you hear me?
We can hear you well, yes.
Okay.
And so let's test right quick that you can move from one slide to the other. So just do a quick arrow. And seems to be working well. So I'm going to mute my mic, and the audience is all yours.
Thank you very much, Marcus, and good morning as well from Germany. You already introduced my topic, so I just go on. So basically, there are a lot of strategies that comprise health information that is delivered through mobile devices now or currently. For example, we have a lot of health apps and mobile services that are also bearing the potential to enhance empowerment for diabetes self-management, because here we focus on diabetes self-management. So what is our interest? We looked at studies that are actually testing effects of mHealth interventions. First of all, we looked at 22 systematic literature reviews and meta-analysis on did some studies on effectiveness of mHealth for diabetes self-management. And if we look at them, 17 out of 22 reviews actually reported positive effects of mHealth interventions. None really clearly report negative results. For example, there is one meta-analysis by Wang that reported a significant reduction of HbA1c, that's actually blood glucose value, in 22 diabetes mobile phone intervention trials. We should also be aware of a possible publication bias here. So in these 20 reviews that we looked at first, there are different things reported. Mainly, first of all, of course, the outcomes. Then, as well, the type of diabetes, the length of intervention, sample size, of course, and the type of study design. And then some details on the interventions, very briefly, and study aims, mainly. In addition, the meta-analyses mainly also report a comparison of reduction in HbA1c across studies and subgroups, so effect sizes basically. But actually, if we look at these reviews and meta-analyses, there is kind of a lack in reporting these mHealth effects in relation to specific characteristics of the underlying study design, especially the intervention time frame. So this means like the frequency of messages, number of follow-ups, length of intervention, and so on. But this is important because the study design actually can qualify the effects. So if we think about it like, for example, we have a short intervention duration in an mHealth study, and this can actually lead to an overestimation of effects. So if we think of there is an mHealth intervention and the enthusiasm for the usage of this mobile program actually should be high at the beginning of the intervention, but then fading away over a longer period of time. So actually, if we just have a study that has a very short study duration, we would actually just capture the very first phase of this, but not the fading away. So our research question, first of all, was this: how do reported mHealth intervention effects depend on or relate to characteristics of the study design in diabetes management, especially regarding the time frame of the conducted study? So in the second step, after looking at the reviews, we searched for mHealth effect studies in 11 databases with the keywords on mobile, diabetes, and the various variations of the study design. You can see the databases on the right. And then, actually, in a second step, we will also include all the papers from the 22 literature reviews. So here you can see the flow chart. I don't present it now in detail. At the beginning, we had 1,249 results, and we ended up with 135 papers that included various kind of studies with kind of different mHealth interventions. And here, I want to just focus on SMS interventions. So these were, in the end, 33 SMS interventions. So our inclusion, basically, what kind of studies or papers we included were both diabetes type 1 and 2. Then we had, of course, various study designs. Then also various effects, but we kind of had hard type of effects, so HbA1c values that really tell something about the health status. Then the technology, of course, and then the stimulus in this way was SMS. So we focused on SMS interventions. We then conducted a preliminary intercoder reliability measure, which is really preliminary because this is just the first step now. And for the inclusion-exclusion of papers, we actually found 82% agreement, which is not too good, but for the reasons of exclusion was 92%. And then this was basically for inclusion and exclusion of papers, and then in the second step, the 33 papers were coded by one coder to guarantee really comparability. So if we look at those 33 SMS interventions, we can see actually that these are mainly clinical settings, or they were done in clinical settings at hospitals or research centers that are specialized on diabetes. The studies are from various countries, and both type 1 and type 2 were included on diabetes. The study participants here were almost exclusively patients, of course, when it's clinical settings, and the majority is adults. Some also focus on children or adolescents. So the majority of these studies are kind of longitudinal and have a group comparison, but they hardly have any theoretical foundation. This was really a clear result. And the sample sizes of these 33 studies vary with a tendency to really small samples, like less than 100 at least. The short intervention durations appear quite frequently, even less than 3 months, for example. And the majority of the studies is simple pre and post testing, and some even don't use a control group. So the majority design was actually one baseline measurement and then only one follow-up measurement. And few studies really have more than one follow-up measurement. And mainly it was like one intervention, one control group, or even no control group. So we see that this was basically the majority of studies. When we look at the frequency of messages, it's mainly one or several times weekly that messages are sent out to patients. And now on our actual research questions, these are just results in progress, like work in progress, because we're still going on with the review. Actually, the HbA1c value was the only outcome measure that actually the majority of studies have in common. So the outcome measures really vary a lot. The majority then reports positive outcomes for HbA1c, and some report no effect. The problem here is also that the HbA1c values are hardly comparable across the studies. If we look at the design of the study as well, excuse me, because the design aspects and the specific focus of the research questions vary a lot in the study. And as well, there's a big or a large variation in the sample composition of the studies included. So if it's type 1 or 2, if it's children or adults or different age groups. So the selection criteria of the patients vary a lot. So we can see some tendencies for our research questions. The studies with a shorter intervention duration didn't really show a higher frequency of reporting HbA1c changes in comparison to interventions with a longer duration, what could be expected mainly. The message frequency is also only interpretable in combination with the intervention duration. The number of follow-ups hardly varies, so here we can tell no differences at all because it mainly was just one follow-up. And we have a tendency that studies with more criticizable study designs actually report more favorable results regarding positive effects. So here we can ask, or it might be kind of an oversimplification of the results. So one first conclusion is that it's definitely not sufficient to measure mHealth intervention effect in a small sample with only one control group in a short intervention period and with only one follow-up measurement, which is kind of seems to be a bit the standard. So the study should comprise at least several follow-ups in a suitable control group to really detect changes that are caused by the SMS intervention in basically a longer period of time, so we can really see the process if changes can be tracked. And something that really appeared was that the quality of many studies and papers is insufficient. There was the impression of a very selective reporting and also kind of missing data in the papers. So what is our next procedure, just to sum up? That we want to add the papers that were included in the literature reviews and meta-analysis to cover a broader search of papers and studies, because they had different search strategies as well. Then we, if it's possible, we want to compare the effects and calculate effect sizes for comparable studies. Then we also want to extend our focus, not just looking on SMS interventions. The limitations, of course, might be that our papers were mainly in English, or basically only in English, and that there might be a publication bias, that studies actually reporting no or negative effects are less likely to be published. So that's from my side. Thank you very much. And I switch back.
Well, thank you very much, Nicola. For our audience, if you have any questions for Nicola or our previous presenters, please post them on Twitter with the hashtag VCU Global Health, and we'll bring them into the discussion at the end of our panel. Our next presenter is Weirui Wang from Florida International University in beautiful Miami. The paper is Influential Weibo Users' Causal Attributions of Depression and Stigmatization Opinions of Their Followers. And so let's pull up the PowerPoint as well. First, make sure that it works, that you can move back and forth.
Okay, can you hear me right now?
We can hear you very well.
Okay. I think I can't use the full presentation, so I will move like one slide by slide.
That is fine. Right now we can't see your presentation, so you would have to click on the left side. Now we can see it.
I move slide by slide. Can you see it?
Yeah, and this will work. This will work just fine. So if you want to go to the beginning, and then the audience is all yours.
All right. Okay. So our project is about how depression is portrayed in discussion in Chinese social media, and we look at whether the opinion leaders and mass media have certain impact on their followers. We focused on depression because it becomes a global epidemic. According to the data from World Health Organization, globally 350 million individuals are affected by this disease. But interestingly, the rate of depression in China is low. And some scholars said, okay, it's not because depression is less serious or less prominent in China. It's because some of the cultural reasons, for example, high tolerance of stress, or considering it as a neurological weakness instead of disease, lead to the low rate. Depression is also an illness associated with stigma. the stigma devaluating people with depression and make them less likely to seek for treatment, and also lead to less tolerable social attitudes. So for our study, we want to look at, with the use of social media, whether the definition of depression, social construction of depression, is changed in social media. The reason that we focus on social media is previous studies already suggest that it transforms the way information is disseminated. It changed the way public opinion is formed, and it actually changes a lot of definitions of a lot of public issues. Talking about depression, the way that we attribute depression can actually lead to different extent of stigmatizing attitudes. So there are two ways of making causal attribution: external and internal. Let's say if we attribute depression to external reasons, usually it means that we think this disease is uncontrollable, so patients who are diagnosed with the disease are less blamed. But if we attribute depression to internal reasons, it's suggesting that people should be responsible for responding to medical treatment. They are the ones who causing their disease. So patients are actually more blamed for causing their own illness. And previous studies suggest that for mental illness, the most frequently attributed reason is environmental reason. So for example, the life change, accident, work stress cause depression, followed by genetic or biological reasons, and then parental, and then personal. For our study, we look at whether the causal attributions are how that is made by the influential users in Sina Weibo. We focus on Sina Weibo because it's one of the most popular social networking sites in China. It was launched in 2009, but actually a lot of issues are debated or discussed in Sina Weibo, and the previous study suggests that the issue discussion actually challenge governmental legitimacy, change the definition of a lot of social issues. When we talk about Sina Weibo, we can't ignore the emergence of big Vs. Big Vs refer to the people New York Times call them the online opinion leaders. They are the people who have a lot of virtual connections, so they have certain impact on their followers, and they become important information sources for their followers to get updated about current issues. And in addition to big Vs, who are the opinion leaders, accounts are still the important information sources for people in social media. So our study look at how mass media and public opinion leaders make causal attributions for depression in their posts, and we also look at whether the various types of causal attributions can actually influence the stigmatizing opinion expressed by their followers. The third question, we compare the impact of public opinion leaders and the mass media to see who demonstrate a bigger influence on their followers. So what we did is we did a content analysis. We locate the depression-related posts from the influential users. We locate 102 original posts from them, and we also look at for each post the first 50 comments and first 50 reposts from their followers. The reason that we look at the first 50 is we want to only look at how the influential users affect their followers by excluding the impact of early followers on later followers in responding to the issue. So this chart actually shows you how we collect our sample. On this chart, you can see an original post at the top. Okay, and here you can see how many reposts and how many comments this original post have. We go to as I said, we go to locate the first 50 reposts and first 50 comments, and we exclude the response posts that are too vague. For example, there is just a smiling face, or it just saying, okay, I'm retweeting, I'm reposting in, but didn't contribute any original content, because all of this is too vague to code, and we have to code whether the response post express any stigmatizing opinion. So we excluded all of these posts, and then we collected in total more than 8,000 response posts. For the original posts, we go to analyze, okay, whether it's from a public opinion leader or it's from a mass media account. And we also go to analyze the causal attributions. For example, the presence of personal cause, parental cause, environmental and social cause, and genetic and biomedical. Personal would be character flaw causing depression. Parental will be parental abuse in childhood, for example. Environmental and social would be work stress, life cycle change. Genetic will be, family genes that causing depression. And for the response posts, we look at whether they express a stigmatizing opinion. And the stigmatizing opinion would be devalue people living with depression, stereotyping them, discriminate against them, consider them as abnormal, lazy, incompetent, things like that. And we code all of these posts after establishing the intercoder reliability, and we conduct chi-square analysis to answer all of our research questions. So here are the results. The table 1 shows the results for the RQ1. It shows how these influential users made causal attributions for depression. From this table, you can see that environmental cause was the most frequently used causal attribution. And we also compare whether the public opinion leaders and mass media made similar causal attributions. And for environmental, it's significantly different. That significantly, mass media made the environmental causal attribution significantly more often than the public opinion leaders. And then we look at, okay, whether these various types of causal attributions actually influence the stigmatizing opinion of their followers. And from this table 2, you can see that personal cause, parental cause, and genetic cause, whether the presence of this type of causal attribution will not influence the stigmatizing opinion of the followers. However, environmental cause, if the influential users made such a causal attribution, the response post will be less likely to express a stigmatizing opinion. So basically, environmental causal attribution can reduce stigmatizing opinion of the followers. And RQ3, we look at whether the public opinion leaders and mass media have certain similar level of impact. And table 3 shows you the results. And you can see that if public opinion leaders made made an environmental causal attribution, their followers are less likely to express a stigmatizing opinion. However, this pattern was not found in reaction to the mass media. In other words, if mass media made such a causal attribution, it didn't really influence whether the how frequently the stigmatizing opinion was expressed by the followers. So, putting all of these results together, it shows that even though mass media are the actors who made environmental causal attribution more often, but talking about the impact, public opinion leaders are the people who have an impact on their opinion. Only when they made such attribution, it could reduce stigmatization. So in general, our study found that the big V's, the opinion, online opinion leaders, they have their power, their influence to influence their followers. They can actually set up the agenda on public health issues for their followers, and also emphasis on environmental cause of depression can actually reduce the stigma associated with the illness, so it can be used in future health campaigns and education efforts. And for health campaigns, based on the results of this study, we can actually use the celebrities or the social media influencers, using them as a spokesperson for a health campaign about depression, and they can deliver the message on environmental cause of depression, which could reduce stigma associated with the issue. So this is the first step of our study. We will continue to do some research comparing the effects of mass media and public opinion leaders in social media, and we welcome your suggestions and questions. Thank you.
Great, thank you so much, Weirui, for this presentation. For all of our audience members, please post your questions on Twitter using the hashtag VCU Global Health. And now it's time to turn to our discussant, Rob Logan of NIH, to give some feedback to our presenters, and then afterwards we'll open it up for a few questions from our audience. Rob?
First, can you hear me, everybody?
We can hear you very well.
Very good. That's good news. And then second, Marcus, tell me how much time I have. Approximately.
You still have 10 minutes. We'll probably, for all of our audience members, we'll probably start our professional panel, which is scheduled for 11:30, probably a couple of minutes late since we're running a little behind. But that's fine. So. Okay. That tells me basically what I need to know. You know, it's really rare that I read papers that span my entire career, as both at NIH and as a mass communication journalism professor, but these three papers actually do. Okay, that's an extremely rare occurrence. These papers are all off to a perfectly good start. I assume that you want to publish them someday, so my remarks are all intended to help you prepare manuscripts for publication. I repeat what I just said. My remarks are intended to help you prepare a manuscript for publication. They're not based on they're an inference, okay, from what you've said today and what I've received. I could be wrong because they're inferences. Let me go to Europe first. I'll do Florida second, and I'll have Georgia third simply because I know Jan the best. She'll be the least nervous about being last of anybody. So let me do it that way. Let's see. If you're going to look at the systematic review about diabetes self-management interventions, there are more than 24 systematic reviews in PubMed Health about diabetes self-management, and there are more than 24 systematic reviews there. In fact, if you do a second search, you'll find more than 60. Okay,
So the question is, okay, how do you as a writer, okay, how do you distinguish yourself, okay, from the systematic reviews that have been done? By the way, there's some of those systematic reviews that are quite recent, okay? That's the first challenge you're going to have as a writer, okay? The second challenge you're going to have is that a good systematic review, the ones that I find exceptional and really helpful, provide a rationale at the beginning of the manuscript that talks about the clinical implications, the healthcare utilization implications and outcomes, the behavioral and health promotional outcomes, okay, of the particular topic that you're looking at. So I think, again, this is not something you do for a PowerPoint presentation, but for a paper, start with the rationale of why it is important to do systematic review of interventions of diabetes self-management, okay, in terms of its potential clinical, healthcare utilization outcomes, behavioral outcomes, and health promotional outcomes. I think the paper will be much stronger with that kind of inclusion, with that kind of introduction. Next, the study design. You basically argue that the most important thing in terms of intervention is based on study design, and the study designs sometimes overestimate the effects. But as far as I know in the materials that I received, there's no mention of patient characteristics or social determinants of health, okay? If you're not going to look at those things, okay, you need to say so. You need to explain why you excluded them. If they aren't there, okay, in most of the things you reviewed, then you have a finding that eclipses everything else that you've discovered, okay? Because essentially the entire health disparities literature all over the world would argue very strongly that social determinants of health and the clinical literature would say patient characteristics are by far the most important predictors of those things. So you deal with those issues if you can, all right? If they're not, believe me, if they're not in all the studies that you reviewed, or if they're not prominent or significant, or you can't use them in order to show any differences among interventions, then for goodness sakes, you got an important finding right there. Turning now to the study in Florida, your results suggest that you've done a pre-post test, okay? But the problem is that you haven't done a pre-post test. In order to do a pre-post test, you would have to know the opinions of the people, okay, of the followers, okay, before the intervention, okay. So I would suggest that you think again about the fundamental nature of the study itself. It looks to me like it's far more a communication diffusion study or an agenda setting study, okay, not a pre-post test. And the way you're reporting findings, again, you don't have to change the study, but you need to change, I suggest, the way you frame it, okay? And because I think right now it's not framed optimally, okay, depending on the results that you have. You need to talk about the context in which the study was done. For example, if you do a study about depression during the era in the U.S., just as an example, I realize yours is not in the U.S., but if you did one in the U.S. after Newtown, the Newtown killings, okay, you would get a very skewed view of depression, okay, in comparison with other times. So you need some discussion, okay, within the paper about the contextualization of depression or events that were occurring in China at the time the study was done. It doesn't have to be lengthy, but it needs to be there. You're arguing the users are a special population, okay? If you argue the users are a special population, the followers, okay, if they're a special population, then your findings automatically are not generalizable, and you need to deal with that issue as a writer, okay, very strongly. You need to explain your assertion that the blog, people who are on the blog are public opinion leaders. I'll take your word for it, okay, but you need to explain that very much to an international audience, why you can make that assertion, okay? I'm sure you can, but again, that's something you need to do briefly, but you need to do. Next, your research question number 2. This is a matter of semantics, but you cannot answer the research question from your data set, okay? You're looking at associations or similarities between groups, okay? Not the way you've set up question number 2. So again, you don't have to change the study, but you need to edit, okay, very carefully how that's written. So the question itself can be answered from the data that you've gathered. All right? Okay, I'll stop there and I'll turn to the paper from Georgia. This basically is, they ask a question, what predicts college student use of mobile health apps, and the answer is multiple platforms, features high self-efficacy and anxiety. At least that's the finding so far. Is motivation a dependent variable in the study? It shows up 2/3 of the way suddenly in the PowerPoint. Okay, if it is a dependent variable in the study, it should move up much earlier. If it's not a dependent variable in the study, I would just take it out altogether. Also, are you using uses and gratifications to look at motivation? Okay, I think you are, but I'm not sure. Okay, so that's something you just need to clarify. All right. The other dependent variables are very clear, but that one not less so. Okay, so just clarify that one somewhat. I suggest the inclusion, okay, theoretically, or an explanation of the exclusion, either one, okay, of the health belief model, of the patient activation measure or scale, okay, and health literacy. By leaving those three out, you're automatically going to get a number of people who question why you didn't ask those questions, okay, or why you did not include them. By the way, if you haven't seen the patient activation measure, that is very good to use for college students. Okay, it's any college student can do that, and it provides a very good measure of, at least in terms of grounded evidence-based measure of motivation and several other things that you're interested in. And again, all I have to do is Google patient activation measure, and you'll have what you need. The last thing that I'll say goes back to the first paper because I neglected to make the point, the paper from Europe. When you listed the kinds of resources you use, you did not mention PubMed Health, which was a big surprise to me. You may include it when you say PubMed. That may just be a matter of semantics. But if you didn't include PubMed Health, you will definitely be asked why you didn't. So I would suggest that that you have that inclusion. Marcus, I think I'll stop there and we'll listen to everyone else. Thanks.
Great, thank you so much, Rob, and I greatly appreciate always Rob's feedback on research papers. I've witnessed him on a couple of panels at AHMC, so I always feel that it's great to get feedback that will get you ready for publication, and I think that's what we just got from Rob. So thank you very much, Rob. Let's turn to my colleague Scott Sherman and Osita Reku in our audience room and see if we have questions from our audience room.
Hi everyone, clearly I'm not Scott Sherman, but he realized that he left his car parked outside, and knowing all of us academics that these campuses like to ticket us, so he asked me to kind of take over for him and see if there are any questions from our audience room here and for any of the presenters that we had for this panel. No.
They're also quiet.
they're just taking it all in, Marcus. They're just, learning. But we have some questions from Twitter. Do you want me to read some of those questions, or do you want to? So actually, one of my questions that I posted on Twitter is for Nicola on her study. And as an e-health researcher myself, I was kind of wondering. You mentioned that a lot of these interventions had a lack of a theoretical framework or foundation. I just wanted you to kind of elaborate on that more and maybe think about or talk to us about why do you think that is and how we can move that forward so that we can have theory backing up these kinds of interventions, not just diabetes, but with mHealth in general.
Thank you very much. I mean, this was more a comment, right? So.
Omina?
Or was there an actual question? I didn't.
Well, I understand that it was a comment, but I don't know if you had any thoughts on, why that may be the case, or how, you know, we can kind of move practitioners to utilizing theory in developing interventions, or how we can do that in our own research with mobile.
So you're hinting to the missing theory, right? Did I understand correctly? Okay. Yeah, actually, I think many more studies should be theory-based, because I was surprised myself that so few studies are really based or use health behavior change theories or any other theoretical foundation. And I think studies could be much more, or could like draw more from the theories in like thinking about the outcome variables, for example, because if they are theory-based, they have some better foundation in their argumentation. So very few studies actually used some theoretical foundations. More, it seems more to be a very applied field with very practical thinking. So they just come up with their ideas and probably also go back to other studies that already used outcome measures, like the HbA1c value is very common actually.
Hi, so we have another question from Twitter for Yan and her grad student in regards to the connection of anxiety and smartphone use. So can, you know, the use of us on our smartphones, what do you think that, can that kind of increase or decrease our anxiety levels, and can you speak to that in relation to how you're going to implement that in your research?
Yeah, sure. Okay. Sure. That's actually a really, really good question. Well, as we know, anxiety as a type of, well, negative emotion, right? But in fact, actually, certain level of anxiety can work as a motivator, because if you feel anxious, you have this need to do something to reduce that level of anxiety or stress, right? However, if the anxiety level is too high or to a degree not manageable, that can also drive to different types of coping. For example, you can simply choose to deny or to avoid the situation, right? So that's why it's very important to see what type of anxiety, the source of anxiety. Is anxiety about the health condition, you're looking for a way to find a solution, or the anxiety is actually about the technology itself. So for example, Marcus Messner knows this very well. I am a really kind of late adopter, forced to adapt a smartphone, right? I had my really old cell phone until last March, right? So for me, as a researcher, I experienced this technology anxiety, but I learned how to get used to it and actually enjoy that, right? So I think Health mobile app depends on the design, the feature. If there's a good match and good fit between an individual, their level of anxiety, what they're anxious about. So for example, if the anxiety is about the technology, then the user-friendly, interactive interface, the design itself can help reduce the anxiety. That they are more likely to adopt certain type of app to manage. If the anxiety is about the health condition, either to prevent something from happening or to facilitate the treatment or to manage, to monitoring the symptoms, then probably the content, the feature of the app can make a difference. But often it might be a combination of both types of anxiety. Okay, so Yan, do you have anything to add to the anxiety question that our audience raised?
I think most of part you already mentioned. So and because so far I think we made us from a lot of study, we haven't know really which factor influence which factor. So this is why we want kind of like to test and then to see and then provide different even though different or more like the information.
Right, I agree. You know, so Rowena, and also to the audience, you know, in health communication, we talk about like tailored health content, message tailoring, right? So when it comes to health mobile app development, even the health mobile app design, maybe the interface, feature interactivity, and the content, right? So all these needs to be tailored at a really multiple level, and all the aspects needs to be tailored to suit the need, different internal anxiety level, sources of anxiety. So beyond just content, messaging, tailoring. Does it make sense, or did I answer the question at all?
Well, let's see if that was your question. Did that answer it? Yeah. Okay. Marcus, I know that we're at 11:26 now. Do you want to continue with this, or should we break now and get ready for the professional panel?
Right, I think since you have to run over here for the professional panel as well, Rowena, I think we have to leave it at that, and let's move the discussion to Twitter, where people are already tweeting quite a bit. If you'd like to get in touch with one of our research presenters to know more about the research, you can also just email me, and I'd be glad to put you in touch with the researchers for some more discussion. You can, of course, find my email on the center website and on the symposium website as well. So thank you very much to Weirui, Nicola, Jenny, and Yen for your presentations. And thank you so much, Rob. I know you are a very busy man. Thank you very much for spending the time reviewing those presentations and giving great feedback to our presenters. Thank you so much. For our audience, as Rowena already referred to just a second ago, we will have a professional panel in just a minute. We are running a couple of minutes behind schedule, so it will take us a few minutes to set up the Google Hangout, and we'll be posting the link on the symposium website probably within the next 5 or 10 minutes. This next panel is a professional panel of experts who have worked to fight the Ebola outbreak in West Africa, and we have presenters who are actually in Africa right now, and here in the United States as well. So it might take us a couple minutes to put that panel together in the background, but we should be live streaming, I'd say, in about 10 minutes. So thanks again. If you have any questions for our presenters from this panel, please post your questions on Twitter with the hashtag VCU Global Health. Thank you very much for joining us, and we'll see you in a few minutes with our next panel.